Our next session is interaction with our international experts, and I'd like to call upon the dais Dr. Manju Subramaniam, Dr. Chi, and Dr. Deepak Edward, please. Thank you for being here with us. Dr. Manju Subramaniam is an associate professor of ophthalmology, a vitreoretinal surgeon at the Boston University Eye Associates. Dr. Deepak Edward is a professor of ophthalmology and pathology at the University of Illinois, Chicago. And Dr. Chi here with us is a senior consultant in ocular inflammation and immunology at Singapore National Eye Center. Our panelists as well, Dr. Digvijay and Dr. Divakant, if they could join her as well, please.
I think, first of all, a big round of applause for the international experts for taking out time. We're really indebted for that. And, all of us are really looking forward to this session. And it's going to be a bit of an interactive session, all right? So all of you are free to participate. We can have the mic moving around. And so we will, and ma'am, we will grill you with a few questions and obviously, take your opinions and, learn from your experience in the duration of this session. And so what I think Mayank has already done has briefly introduced all of you and the audience here essentially, and we're also having a recording which will be, later on viewed by all the other young ophthalmologists in the country, about 4,000 of them. So, we'll address it in the manner for the young ophthalmologists. So I think to begin with, the first question, obviously, and I think that we can do for each of you, is if you could briefly just summarize your journey from residency and how you've got to where you are, probably. Start with you, ma'am. Dr. Manju.
Great. Well, I'll start even earlier than that. I'll start even earlier than that. I was born in Chennai and we moved to the United States when I was 6 months old. My father is a pulmonary critical care specialist. And so we actually grew up in a very small town in Missouri. I went to school, a college and medical school in Kansas City, Missouri in the Midwest. And then I did my retina fellowship at Tufts Medical Center in Boston. And then I moved on to Boston University School of Medicine. I've been there for 15 years now, after spending 2 years at Tufts Medical Center. Was that what you wanted to hear?
Yes, I think that's a good way to kind of personally juggle it up. So we can use this. Yes.
Well, I have a complex, long history, but I'll try to summarize that. I never wanted to be a doctor. I'll start with that.
That's an interesting start.
Engineering was something that I wanted to do, and an event in early life of chicken pox at the age of 17 complicated things a lot. But anyway, ended up in medical college in Bangalore, did an ophthalmology residency in Chandigarh, and then went to the United States, where I retrained in ophthalmology and also retrained in pathology. Have had an academic career throughout my 25, 28 years in the US. It's been fun.
Yeah, thank you.
Okay, so I'm the same. I didn't want to do medicine. I wanted to do chemical engineering. I didn't like biology because I always think I have a very poor memory and there's no logic in biology. But I ended up doing medicine, and when I wanted to apply for subspecialty training, I was asked at the interview, so why are you applying for ophthalmology? Tell us why you like to do ophthalmology. And I said, I don't. So I think I was the only candidate that I'm here, not because I want to, because I wanted to do general surgery and trauma. And because of that, I had this mindset of wanting to see blood and save lives. When I did ophthalmology, I didn't think about subspecialty too much because it was obvious I would do plastics. So I trained in Moorfields to do plastics with Richard Cullen. And when I was there, we were setting up the Singapore National Eye Center. So Professor Arthur Lim said, you're good in medicine. I said, no, you're mixed up. That's my brother. Okay, he's a physician and I'm not. So he said, anyway, since you keep talking about building up a center, you need to do all these medical disciplines, do uveitis. I said, I'll take up the challenge. You train me, I'll do it. So I did attachment with Sue Lightman there. So I came back and I had 2 subspecialties to contend with. And after a while, I realized that everyone wanted to do plastics because it was surgical. That was where the fun was. And I began to dislike all these people. Oh, I got a bit of skin here. I've got this one half ptosis. I want corrected. And so I said, okay, I'll focus more on uveitis because there's no one really in Asia doing that. So I started to do that. But in the meanwhile, we all do general practice. So we do cataract. And, I always take things that people don't want, the discards, right? So I did uveitis. Everyone wanted to do the plastic cases. I gave them more, and I started to cut down my plastic service. And, all these horrible cataracts, no one wanted. Those that had no zonules, those that were really black and tough. So I said, well, you can toss them in my direction, I'll do it. So that's how I started to do the complicated cases. And after a while, I wasn't so afraid of them, and I started to design tools and instruments and develop techniques to handle these more efficiently. So that's how I ended up now doing more of these complex cases. And I still do a very extensive uveitis clinic, and I've seen patients until 1 a.m., right? Because there's so many patients and so few of us. That's my life.
So I'll add a postscript. So my desire to become an engineer did not stop there. During my career, I collaborated with an industrial engineer. We actually developed a neurosurgical and a cataract surgery simulator on the way. And then also collaborated with a very fascinating engineer from NASA to look at non-invasive tools to look at the vitreous. So it kind of came to a full circle where there was something I wanted to do, but I didn't do. And the funny thing was the biomedical engineer at NASA said, I almost wanted to be a doctor, but never got to be a doctor. So I said, let's swap roles. And we really had a very productive collaboration for several years. So the point I'm trying to make is, I guess, that what you might have dreamt to do, and it can still come to pass. The world today is all about collaboration. You may not have the skills that to do what you want to do, but there are other people who have them, and you can collaborate and make things happen.
So now we'll move the questions back starting from you, Dr. G. Perhaps one of the most relevant questions for all the young ophthalmologists would be the accreditation process for those who are immediately post-residency or post-fellowship, looking at perhaps further training or work in your respective centers. So at SNEC, for example, what would you say would be, so that would be my non-academic question to you, and the academic one perhaps would be your experience in uveitis. So the role of biologics, for example, how much do you use those in your practice at the moment?
I'm not really clear your question.
So the first one would be the accreditation process for anyone who's moving out from India, a young ophthalmologist, taking up either post-residency or post-fellowship positions at SNEC.
Okay, so for fellowship, you have to apply, and you go through an interview, which can be by Skype or it can be face-to-face when you come for a conference. And we take fellows in actually twice a year, but we're trying to streamline that to once a year, like the rest of the world. And generally, I was asked this even this morning because I was giving a talk at Center for Sight, and I was asked, so how do I come and apply for a fellowship? You just apply, and we have numerous applicants from around the region, around the world even, and if you are better qualified, you tend to be picked more than someone who we have to train from scratch, obviously. Yeah, and is it a paid fellowship? We give a stipend, but that stipend is usually enough, and if you come having had one fellowship, say in India, you'll be paid a higher stipend because we feel that you can see more patients, you can contribute more to the center. Yeah, so anyone can apply, right? Yeah.
So we have a tie-up also with the AIOS and the SNEC, and so there is an exchange, so you can apply through that route as well for a short-term observership or a fellowship.
Is this in the UK, Dr. Chi?
Sorry?
Are you in the UK?
Singapore,
I'm sorry.
yeah. So actually, the AIOS has requested that we extend it to 1 year. Yeah, so instead of 3-month fellowships, they now are going to apply for 1-year fellowships, yeah. And you'll be given priority, yeah. Yeah. Even APAO has got a fellowship that you can apply through, yeah, sponsored fellowship.
And I think the second part of the question was now about the academic question about biologics in inflammatory eye disease and uveitis.
Okay, so, you know, our patients are not that rich. Not many of them have insurance in place. And these are usually the younger patients that may need, you know, better control of their uveitis. So we will still step up the ladder slowly, all right? And we would give, I tend to give immunosuppression very early on in the disease. For example, VKH. At the outset, I would start steroids plus immunosuppression. So when it's needed, I would give it. And of course, if, for example, it doesn't seem to work, we would move on from azathioprine, which is my first choice, to methotrexate or mycophenolate, and you know, it would get more expensive. And of course, if it still doesn't work, then we would say biologics. So we do have a number of patients, and you know, many of these patients don't have insurance to pay for them, but we do have means of helping them through a social worker who will look at their financial background, and the center would actually have funds to provide ability to use biologics for these patients. I think the most important view that we have is really patient care. And if the patient needs it, there's no reason why a Singaporean should be denied this treatment. The only problem that we would face is if the patient comes from abroad, then we have no ability to actually fund them. In fact, we are looking at, you know, ability for cases that are really one-eyed and, you know, on compassionate grounds to even look for funding for these foreign patients. Yeah. So I do use biologics quite a lot, but I would still go up the step ladder unless it's like a Behçet's disease where we know that the main treatment is biologics and not going slowly up the ladder, because they would lose too much vision by then.
Right. I think
Any questions
any
from the
questions
audience?
from the audience on uveitis or Singapore or fellowships or anything as of now? All right, just think about it. Oh, you've got one there.
Apart from the short-term fellowship, are there any chance for having observership to be done where we can just go and observe how things are there, and maybe just to go in how the setup is there so that the same can be implemented at different places?
Sure. You just apply through our website. So if you go to the SNEC website and then you apply through the training education program, then they will contact you and ask you when you want to come and for how long and which subspecialty. So we get people in and out, you know, of our ORs all the time, and in our clinics as well. Yeah.
Yeah. Go ahead, please.
Ma'am, so the question is for you. In terms of hands-on, is it better to come to learn something before the Indian fellowship that we do or after?
So it really depends, you know, at which level you come. Say if we take, for example, cataract, right? If you come in having done 50 phacos and you're still struggling, and we look at your standard, we say, well, we can't bring you up that quickly because you have not really mastered your basics. So you kind of waste time just doing what you could do at home, because the number of cases that you have here are so much more than what you can get in Singapore. We are such a small population. Yeah. So actually, to make the most of your fellowship, you want to do as much as you can here so that you're already trained to do the basics. And then you go there, then you learn, you know, the finer points to do the complex ones, and you see the whole setup, you know, how we integrate research and so on with our practice.
Yes, Sagnik, please. Go ahead, Sagnik.
Jobs really is tough. It's tough unless you have a degree that is recognized by our Center for Practice. Generally, you can't get in. So let's say you're a graduate from a medical school that is recognized by by our Singapore Medical Association. That's the only way you can actually get in. Yeah, and then we have to look at your training process, how rigorous it was. Does it fulfill the same number of years and the rigorousness of the any kind of training system that matches ours. And then you have to go through the Specialist Accreditation Board, and when you get through that, then you can get in a position to practice. No, not really. So for example, you know, someone like Lingam Gopal, he's working in Singapore, and his wife, she's an excellent glaucoma surgeon in SN, right? When she came in, she qualified, but she had to undergo a stage of supervision because the training didn't really match ours. You know, although we said she's so great and, you know, she does all sorts of wonderful work and surgery and publications, but it just cannot get through the paperwork. So she still had to undergo supervision, which was embarrassing even for her supervisor.
Thank you. So I think we'll move on to Dr. Deepak. So you're at the University of Illinois, Chicago, is that right? That's what you got. So a lot of times, I think a lot of us are coming to Chicago for the American Academy. It's probably one of the more, popular areas that there is. So is it, how easy would it be, or how should we go about trying to, visit the institute there, or to get an observership, or to come for a short time, maybe spend 3 to 4 days for residents or fellows who are going there all the way for the conference? So that's the first part of the question. And the second is in terms of basic sciences, and I think you've been involved with a lot of that, and glaucoma as well. How deep should residents go? How do you think they should get stimulated to look at more of that in terms of their education and careers then forward?
Okay, to answer the first part of your question, I think it's fairly easy to do that if you're coming for a meeting to the U.S. At the University of Illinois, we have a section of global ophthalmology, and the way to is to contact the person. There's a coordinator who will be in touch with you, and you can come spend a few days or a week with a particular subspecialty. The timing is important. So, people are also getting ready for the academy, so it's better probably to come a week before and spend that week there rather than immediately after the academy, because patient schedules may not match and things are little, so that would be the best time. So, but I can give you the information to have, contact, and we have a lot of people coming to the institution that way. So the second question was related to basic science, is how do you encourage people, or is it, okay. So I think, I think most ophthalmology residents or trainees, ophthalmologists are probably here also among the brightest of the brightest medical specialties, and those who are graduating. I think if there's a sense of curiosity that needs, and I think all of us are curious in this room, and the question is how to get the training to do that, right? So, of course, you have local resources to train. There are several departments in the United States where you can spend time doing a research fellowship. Typically, those are offered by people who have an NEI or NIH grants, and there are postdoctoral fellowships available. It's usually beneficial, similar to the clinical issues in Singapore, where there needs to be some degree of experience. So for example, if you've worked with somebody here on a molecular biology project, or have an understanding of your hands wet, you're more likely to be considered. And we have several people who have done that, gotten the training. Today it's very difficult to have someone come in fresh as a clinician to be incorporated within a basic science lab, and having the scientists there train you. The other way is, I don't think the ICO fellowships are mainly clinical, correct? So there really isn't any specific mechanism. So there's, of course, voluntary time, and that's expensive. There are people who come and do that for a few months, but those are hard to get. So you need some experience, and if you have that, I think then information is available on our websites, and also contacting individual investigators. Just go on the web and look for it. So.
So take it from the basic sciences aspect, the role of basic sciences and translational research is being increasingly recognized. And Dr. Subramanian, you strongly worked on eye-based protein biomarkers for Alzheimer's and diabetic retinopathy. So please tell us a little more about your work and how do you see it develop more in the future?
Yeah, so I would say that I was very clinical when I first started my career. I did do some studies on AMD, macular degeneration. I actually did a head-to-head trial doing really just a pilot project looking at bevacizumab versus ranibizumab in the VA setting prior to when the NIH finished their CAT trial. And so after doing that project, and then after I got promoted to associate professor, I took on a leadership role in our department of ophthalmology, and I was one of the vice chairs, so that took up a considerable amount of my time. So I didn't really get into research until about 4 or 5 years ago, a little bit later in my career, and it was initially the project that I'm working on now in relation to Alzheimer's disease. It started with collaboration with a geneticist in the department who had looked at A-beta protein, that's a biomarker in Alzheimer's disease, and she found it in the lens of the eye. So we collaborated, and she suggested I look at this in the vitreous. And so one of the studies that I have done that has been recently published in the Journal of Alzheimer's Disease was looking at A-beta and tau proteins, which are markers of the plaques and neurofibrillary tangles in the brain, and looking at it in the vitreous humor. So we did a study looking at 80 patients who were just getting vitrectomies for eye surgery. This was a non-Alzheimer's disease cohort of patients, so we did a cross-sectional study that looks at their vitreous humor, and we correlated those levels to their mini-mental status scores, and we found a significant association. So it was it was an interesting trial in that, we were able to find that these levels in the vitreous were associated with a patient's cognitive function and we controlled for age, sex, and education, and we found that on analysis that it was not associated with their eye condition, because that's always the first question people ask, well, what if the beta amyloid and the tau was due to their eye condition? And so, yeah, so that's how I got into doing research, and that actually helped provide the preliminary data for a couple of NIH grants that I've applied for, and I did get one NIH grant looking at
yes,
that.
and that brings us to the next question, that about the R01, R03, you're a recipient of the R03 grant, so how would that be different from the other NIH grants?
It really depends on the size of the amount of money that you're applying for. So R01 grants are really the largest ones. Those can be, depending, I think the budgets are different. It just depends on what the RFA or the request for application will say and how much that they'll allocate in funding for it. But R01s are really sort of the holy grail of grants. That's the one that you want to get. And then the one that I have is a smaller one. The R03s are smaller grants where you'll get $100,000 maybe a year for 2 years, $50,000 to $100,000 a year for 2 years. I'm applying for an R21 right now. That's, I believe, $130 for a year for 2 years. So it really just depends on the budget and the size of the grant, and that's where sort of the R's come in. And then you have your K awards, which are your career development grants. And then they also, have grants that are for multi-institutional international funding too, because they do have Indo-American US grants, which is an R01 grant, I believe, that they offer once every couple of years. And I know there are some institutions that have gotten that. So, yeah.
Great, thank you.
Does that help?
Yes, absolutely, that does. Any questions from the audience, meanwhile?
So not many of us have had the opportunity to visit an international center. So I want to know from each of you, starting with Dr. Swan, how is a typical day at your center is? The OPT, the OR, what forms the bulk of your patients? How's the practice like?
So I think this would differ from subspecialist to subspecialist. And for me, because I do mainly uveitis and I do cataract surgery, and I've totally stopped doing plastics. I tend to be quite busy because I've got 2 subspecialties, and there are very few doctors who do uveitis, and I get the bulk of the patients still. I don't have any free sessions, actually, which I think we need some breather to think and to do our research work.
You said you don't have any free sessions, free
No.
time? You're clinical all 5 days?
Yes,
Of the
and
week.
Saturday as well. I do
And
alternate Saturdays as
When
well.
do you sleep?
I don't. I'm going to get Alzheimer's. So that's the problem, you know, because, and the clinics tend to be busy. And, you know, because although I'm practicing in the public health institution, we see public patients, and we also have a private sector. And the private is private meaning that the center controls everything that happens to the patient, including what they charge the patient. Just that because the patient comes to see you by name, or the referral pattern is not through the public means, they get charged at a different rate, and they get to see you, and you get to do their surgeries. So because I'm quite a popular cataract surgeon back home, I have a very long waiting list for patients to see me. If they miss the appointment, 6 months later. So if they come on my waiting list, even if they're private, it's like 3 months. So I can list like 20 eyes in half a day, and you know, and these are like private patients where we actually spend time counseling and talking to them. So I actually, for the cataract clinics, I need a lot of support staff, and I do have cataract counselors that would talk to the patients, explain to them about femtocataract, explain to them about different lens options, what the risks and benefits and side effects and so on. So I do need all these people to help me, and I also have a doctor that was trained with me for like 15 years back as my uveitis fellow, and she actually has not, you know, come into the same line where she can be promoted to consultant because her basic degree is not recognized. So she's really a very clever doctor. She's Sri Lankan, but she did her medical degree in Shanghai. So she's really a great asset because she speaks Mandarin. And many of our patients come in, the younger generation, will communicate in Mandarin with her. So she helps me in both cataract as well as my uveitis clinics, and although she doesn't do any surgeries. But she has been through that training with us in the past because she did 2 fellowships with us, one in cataract comprehensive and the other in uveitis. So she's actually my right-hand lady. She sees all my patients and helps me. And then of course we have fellows. So our fellows are very, very important to us. So for cataract, I only take 1 because if you want to give them the experience, there are not that many cases really to train these doctors on. And uveitis, I take 3. So, you know, uveitis is a medical thing. You can see the eye, and another doctor can see. But for operation, you can't keep operating on one eye. So we have very, very busy clinics, and especially the subsidized patients, you know, it can be like 120 per morning. And because it gets impossible now that we're doing medical records electronically, we need to type in and so we had to actually cut down our numbers. And we have residents, we have fellows training, helping in the subspecialty clinics. And for the private clinics, I just have this colleague that I mentioned who helps me with it. But I have 3 operating sessions, right? Which means 3 half days. And of these 3 half days, 1 day would be all private. And they would generally be the standard kind of close your eye boring day, right? Because it will all be femtocataract. And the other 2 days would be all the complex cases. So I do a lot of complex cases because they send everything to me. You know, even if the patient's educationally subnormal and cannot cooperate, it's mine. So I have, you know, the downs. I have all sorts of patients, funny postures, squints where you can't see the eye, the thyroid eyes where really, you know, it's stuck up there, you can pull it down. And I'm like operating under the lid and under the brow. And that would be kind of case that we would do on the complex day, in addition to all the lens fixations, subluxations, IOL subluxations, and so on. So, you know, I'm always the last car to leave the center. So it's no fun being my fellow because they're the last people to leave as well. But they have to work very hard, but they learn so much. And especially my uveitis fellows, you know, when they get all the patients in the ward, it's like, even now we have like maybe 4 patients with endogenous endophthalmitis that we're trying to manage. You know, bad uveitis would be admitted as well, but the medical cases are really very challenging to handle. And they get called, they are on call, they will take turns to go on call, but when they're on call, throughout the clinic, they'll be called. If not the medical referral, if not, it's another doctor who's seeing a patient in acute care. And so our fellows are really very busy and exhausted. So if you come to SNEC and work, especially if you get attached to me, be prepared to either two things, okay? My fellows either lose so much weight because they have no time to eat, or they put on so much weight because, oh, the nurse in place, you want to buy McDonald's? Oh, okay, we'll buy this and we'll buy that. And then some of them put on like 10 kgs. And this is real because, you know, they just eat anything, not proper food.
The same question, how is a typical day for you?
Well, I'm almost embarrassed to be speaking after Dr. Chi because I don't practice and see patients 6 days a week. But I'm clinical, I would say about 60 to 65% of my time, where I see patients 2 full days a week, and then I do lasers and surgery 1 day a week. I have dedicated time for the NIH grant that I have, so that's 10% of my time. And then I also hold a leadership position in the department that I have dedicated time to. I'm vice chairman of faculty affairs. When I see patients, I will say I have around, I don't know what your volume is, but it's around 40 to 60 patients are booked in a day for retina, for the retina. Are you a retina specialist, Deepak?
About 40 to 50. Yeah.
40, 50?
Yeah.
Are you also a retina specialist?
Yes.
Oh, okay.
No, I'm a glaucoma person.
Glaucoma
No,
specialist,
not
yes,
retina.
okay.
No.
Yeah, so I think now with the advent of the electronic health record, it's almost impossible to really see more than 40 to 50 patients a day unless you're really willing to work very late, into the very late hours, because the documentation requirements now that, for every patient in an electronic health record environment is actually quite difficult, and it's actually led to a lot of problems with physician burnout, not just in ophthalmology, but in other specialties as well, and that's actually something that I'm actually involved in as well, but that's sort of a side thing. So in my role as Vice Chairman of Faculty Affairs, one of the things that I do is that I mentor the junior faculty in professional development, career development, promotion, and it was something that our department. It was a job that I spoke with my boss about and created this job because it was sort of an unfilled need in our department, where a lot of the physicians in the department didn't feel like they were being that engaged, at least in their own career development and promotion. They were just so busy seeing patients that they weren't really paying attention to their own academic careers. So that is one of the things that I do, and I spend time doing, about 20% of my time. But in terms of my clinical days, so I see patients, I start at 8 a.m. The patients actually start coming in at 7:30. They get worked up by a technician, and then I start seeing them around 8 a.m. and then usually work through lunch, and then usually I'm done around 4:30, 5 p.m. in the evening, and then I head home to the kids. Those are my clinic days, and then and on my Fridays is when I operate, and I operate anywhere. I can do anywhere from 4 to 6 cases in a day. Our OR days start at 9 a.m. on Fridays, which has actually been quite nice. When they first, most days of the week, our operating room starts at 7:30 in the morning, but on Friday they've decided to dedicate early morning hours to academic time. So we start on Friday, which I initially fought, but I'm really enjoying starting at 9 a.m. instead of 7:30 a.m. on Fridays.
Okay, so I lead a rather complicated life. So in the U.S., I was working in the Middle East on a leave of absence for about 4 years. Came back to the U.S. in 2017. But the last year, on the glaucoma service, I see patients 4 days a week. I operate once every other week, glaucoma surgery, and also scrub with the residents and fellows, and also my private patients. I take call once a month. I also am vice chair of education, so I take care of, oversee the fellowship and the residency programs and work with the program directors in each fellowship and the residency program director. Research time is usually in the evenings or on the weekends. That's where it happens. I also sign out eye pathology cases, and that is as and when they come in. I remotely teach 8 programs ophthalmic pathology through a remote system around the U.S. and so also to the American University in Beirut. The last year I was also bridging my time in the Middle East. So also, they did not find a replacement for me. So between 4 o'clock in the morning and 8 o'clock in the morning, I worked remotely to help with the research and training programs in Riyadh. So it's been a busy time. But I think time management is the key for young people. Also, you get overwhelmed, and I'm not advocating that you work like me. My wife calls me crazy, but I enjoy doing it. I have funding in different areas of research, and most of them are collaborative. And so I have people in the lab who are very good, and I can, delegate a lot of things for those things to happen, and that's why this happens. Just another resource for people, or young people thinking about doing research, which just came to mind while others were talking, was something local. So there are at least 2 universities, one in Europe in Amsterdam, the Maastricht University, and another one in South Africa, the Stellenbosch universities, who will offer PhDs in basic sciences or translation sciences, where you do the research in your country of origin, have a mentor locally as well as a mentor there. There are some programs, I think, in the country which you can do it without charge. You don't pay any fees, except for something very basic that you need to pay, and the PhD takes somewhere between 3 to 4 years to do. So you can do your clinical work and work part-time on this PhD program. So I know there are several people in the country who have done that and are doing pretty good research work. So that's another resource to get trained in basic sciences.
That's an interesting and that's a very valuable input. So we have some questions from the audience, all right.
My question is for all 3 of you. One thing which stands out in the discussion is the kind of changes you have been through in your career, from clinical one specialty to another, and even from clinical to research. So what I want to know is that as young ophthalmologists, we tend to do fellowships and we tend to become labeled into one particular field. So how difficult or easy it is to move from one subspecialty to another and to justify for why you're moving? And then what are the pressures and difficulties which one can face while making such decisions in their career, early or late?
So just, the question is about switching specialties? Going?
So what I wanted to know was what are the changes one actually goes through when one decides to shift specialties? Because you have already invested a lot of time in your career while pursuing one. So changing to another, what are the difficulties that you feel, and how do you choose for center to move on to a specialty? Because if you apply for a different specialty, a common question which come across is why? You have been doing it, why are you not pursuing it further? What is the thing which is making you change? So in your case, it was, I think, the institution you said that they gave you a particular task to follow. But in general, if somebody wants to move from one specialty to another, how to go about it and how to justify that move?
So I think that our center is getting pretty full. So we have like 30 senior consultants, 20 consultants, and then we have associate consultants and residents, and throughout Singapore, all the places for consultant positions and all that are pretty full. So if you ask, do we need another glaucoma specialist? Not really. Do you need, this, do you need that? And yes, the medical specialties will need it. But those who opt for medical specialties feel a bit insecure. I have no surgery. I wanted to do surgery. So we actually allow them to straddle. So like there's one doctor who's doing glaucoma and neuro-ops, because you have to look at the nerve, So she's straddling both. And she does research in AMD. Okay, don't ask me how it happens, but research is slightly different again. But she's doing well and she's happy, so she straddles a lot. Okay, and we allow this to happen because we don't have like a full position for clinical position, because we don't have perhaps that much work. to sustain one full consultant. So we allow them to kind of do both. And after some time, you may say, all right, I've done with my research. I want to focus on surgeries or whatever it is. And then you can just say, I want to choose this subspecialty. So for myself, you know, when I decided to let go of plastics, because I still had patients coming back and said, you did my mother, you did my friend, and I want you to do for me. And I'll tell them, yeah, that's my past life, you know? And it was with a certain amount of fear and trepidation when I took that stand, because as you rightly said, I spent time, I had really been doing that. I've published papers in plastics, but now I was like rethinking my career direction, because I saw I had so many colleagues who were just so happy doing plastics, and I thought to myself, you know, but no one is doing uveitis. I know it's not surgical discipline, but I think I can contribute. And if I stay in the public service, then it's fine. It doesn't matter, right? But if I start to go out into private, I've lost my skills. So that was a great worry. And then, of course, when I've always done a reasonably good job in cataract, even from a junior stage. And I just had so many patients, even though I was not like specializing in cataract. That gave me the confidence that it doesn't matter if I were to leave and go out private, I'll still have my patients. So that's when, you know, and I saw the importance of doing a good cataract when you handle uveitis cases. Okay, because you need to be a gentle surgeon, and these are very challenging cases. You have to dissect membranes. You know, you think retina people think they have the most difficult cases, peeling membranes. I say I peel membranes in the front of the eye. Okay, so I kind of saw that it was important to be a good cataract surgeon. So that's why I focused a lot on developing my cataract skills while I was doing mainly uveitis. So, you know, I think as long as you have patience, you're a good doctor, you're a caring doctor, and you can provide that service. I just didn't feel the fear of switching, because I knew that whatever I did, I would do it to the best of my ability, as long as I had my patience, because that's the most important thing. Yeah. But you really have to think carefully whether, when you're switching, whether you're going to be able to contribute more in that field. If you think the answer is yes, then I think you should not worry, and you can always explain that, you know, I've been there, done that, and I think I can contribute more in this field. And if, you know, your director looks at you and says, why do you want to change? You say, well, I've got some research in this field that I can show you. I've collaborated with this, and I find this is a growing field. I can contribute more. Then that would be a good reason to switch.
Specialties in a way, glaucoma.
Yeah, for me it was not really separate. It was a marriage of two specialties, and so I used my pathology background to do research in glaucoma, but ended up doing most of my actual funded research in retina. So it was, you know, you think of it, so I've used pathology as my background, and then married different parts of the eye as my research background. I mean, clinically I do, there are two separate specialties, you know, clinical ophthalmic pathology and glaucoma, two different things. I just do both of them. I enjoy doing both of them, so I just do them.
Yeah, you know, I think if people told me I'd be doing research in Alzheimer's disease 5 years ago, I would have thought that they were crazy, you know? So that, you know, as a vitreoretinal surgeon, that's what I am clinically, that's what I do on a day-to-day basis. But my research interest is actually looking at, you know, Alzheimer's disease proteins in the eyes. So I think to answer your question, you know, a lot of it depends on multiple factors. One is, you know, the culture of the institution that you're at, right? And is there, are they receptive to changes in specialty, right? Now that being said, putting that aside, the other thing you have to think about is what is your interest, right? And I think that's what Dr. Chi is essentially alluding to. If you're interested, you're no longer interested in doing what you're doing, or you want to supplement what you're already doing, you know, and on top of that, there is an unmet need in your institution, or there is a need for more, for example, if you want to transition into pediatric ophthalmology, if there's more of a need in that specialty, and that's where your interest lies, then, you know, I think that should help with the transition process. But there has to be sort of a need, I think, you know, to help justify a transition to that, or go someplace where there is a need, potentially.
I would like to put up a question. My question is basically to the women mentors here. Besides the academic, I wish to put up a personal question actually. Because being a female in India, we feel that if you have a break in your career, like you have marriage or you have children, then there becomes a big bump that you need to overcome and cross once again to retain the same position and the same zeal with which you started, and then to go ahead in your career. Does it apply same for international fellowships also? Like, do they have to put behind their family and go ahead with the career, or do you feel that if there is a break in the career, there is some drawbacks or they lag behind? Do you feel that?
When you say break, what kind of break are you talking about? Like how long?
Maternity break, for example, some may need 2 to 3 years. Some may
2 to 3 years?
Some may require 2 years. Because after that, with the amount of research and advancement that is going on, people move ahead so fast that you feel that you are behind and you tend to fall back. So do you feel that this does happen in your place, and how do you overcome it? I don't know.
Yeah, I can answer that question.
That's more
We're faced with faculty who have had this issue, or even not residents or fellows, but faculty, junior faculty who have gone through similar situations. So one or two things, usually when they come back and they're not confident, we usually have someone mentor them for a little bit. So for example, in the OR they have someone look over their shoulders for a week or 2 weeks, or sometimes a little bit more, and they just gain back confidence, and we really don't require them to do some extra CME or something to come up to date. And this usually happens where the faculty has been hired because we know they're good and that they are committed. It just happened that event happened in their life that they had to take some time off. So, but it's difficult. I can see the other side too happening where you are at no recourse. We had another faculty many years ago, and she was out for several years and then actually could not renew her state license. And then they put very stringent requirements for her to get her license back. And long story short, it never happened.
This Illinois license?
Yes.
Yeah. So, I mean, I would say, it depends on the length of time. I think if you're talking about 2 to 3 years, it varies. It varies based on the person, and it varies based on the state and the institution. I will say, though, that from your own personal perspective, everyone seems to think that there's a certain timeline that they have to meet to achieve certain things in their career, And honestly, I think you can take things at your own pace, depending on what you want for yourself in your career. If you just want to see patients and operate, that's great. Taking a break can affect your surgical skill set, but as Deepak said, if you have someone mentoring you through a transition of getting back to work, then it should be fine. If you're looking to be in an academic career, people take breaks, people take sabbaticals all the time, and just get right back into publishing. Yes, you may not get promoted to associate or full professor the same time as your male colleagues, but you'll get there as long as you put the time and the effort and the energy, and you can't feel like you're somehow a second-class citizen because of that. It is that feeling, that's that sort of imposter syndrome that a lot of women have, and eventually you'll get there, and it's okay to wait a couple years, and it's okay to do that as long as you're in an institution that's willing to support you in your transition back to work. That is a risk. that is certainly a risk that you take. I mean, it again depends on the culture of the institution that you're in terms of how receptive they are to time off and bringing you back in. Yeah.
Yeah, so I think it's a choice, a personal choice that you make.
Right.
Because you can't have everything in life. Okay, you either choose to go maternity, look after your family, and that's your priority, or you try to balance a bit. So I can tell you, I've got 3 children, right? And the third child, basically in Singapore, at that stage, it was 2 is enough. So when you have the third, you have no support. So I don't even have maternity leave. I take annual leave. Okay, so after 2 weeks, I was back at work. Okay, so you think about all that, and because to me, it was important to just continue. And fortunately for me, I have home help. I have parents who can look in. I've got helpers there to provide that support. So I think it's something that you have to discuss with your husband if that's what you want to do, you know, and whether he's going to be the sole breadwinner while you take off. And, you know, all these things have to be talked through. But in the end, you can't have everything. So like, you know, the first question I was asked is, how many hours do you sleep? So if I work 6 days a week, I have very little to do research. And if I still want to do research, it eats into personal time. It's a choice that you make almost every day. Do I want to rest? Or should I read this paper? Or should I just stay back and attend to this patient? But it's a choice you make all the time. And it depends on your priorities and what drives you, what gives you that satisfaction. Ultimately, what you want is to be happy. Okay, so I sleep like 3.5 hours a day. Sometimes I worked on a paper through the night, and my helper comes in. I'm supposed to wake you up at 7, but you're awake. I said, I have not slept. So, you know, it really depends on what you want in life. So you can achieve it, but there is something that has to be sacrificed. It could be your own personal life, your health, your whatever. But, you know, we are only given 24 hours. So if you take that time to do, you know, start a family and look after your family, then you have to lose out on seniority and you're left behind and it takes some time getting back. But in the end, it's your choice. And if that's what makes you happy, then go that way. Because, you know, you cannot be so ambitious and yet you want to have your family and everything, you know, that a mother would want for the family. So I think, you know, women have to make a decision. And in the end, you know, we have this thing called women in ophthalmology, and you know, I've refused many times to speak there because I always say that the opportunities to a certain extent are equal. Not exactly equal, but the opportunity is there. It doesn't mean that if you want to raise a family that you have to give up a career. You just need to balance it. And so you may not be able to go all the way as you would have done if you were single, right? You cannot commit so much because you need to commit time to your family. But it's a choice that you make. And so you should be happy with the choice that you make. And, you know, don't expect that, oh, I take 3 years off, but I should be the same seniority, I should be given the same, you know, promotion, etc.
Yeah, and I would also challenge the notion that, you know, women necessarily have to take time off soon after. I mean, obviously for physical recovery, you need to take time off. But, you know, in Europe, for example, they're given 1 year of maternity leave. Their job is ready for them and waiting for them when they come back, you know, which is great because that's the system, that's the culture of the country and the system that they have in place. For me, personally, I have 2 boys, 12 and 15. And for me, it's actually more important now for me to be around for them than it was when they were a year old, you know, 1 year old, 2 years old. I'm very glad that I didn't take time off at that young an age because I had help, I had support. I felt like at that age they only need a warm body, but right now that they're 12 and 15, they need me to be around so that, you know, these are emotionally tough times for them, and that's when they need me to be there. So I went kind of the opposite direction what a lot of women do, where they take time off as soon as the children are born. But I actually worked really hard when they were young, you know, tried to get my career on the path that I wanted, and I became to a point in my career where I was a little bit more senior and I could dictate my schedule a little bit more. As I became more senior, I had a little bit more clout and I was able to, you know, cut back here and cut back there and do, you know, less clinics, and it was easy to do, and I'm still considered full-time, you know. So for me, that worked out very well, and that's what I advise a lot of women is, you know, you want to take time off after the babies are born, you want to take extended leave after the baby's born, that's great if that's what you want to do. But don't assume that you have to do it because that's what all the other women are doing. There are other ways to do it, to go about it.
So, you know, my daughter was 2 months old when I left for Morpheus. And I left her at home. 2 months. Today, she is a resident in ophthalmology.
So those were very insightful experiences, and I really thank all of you panelists for sharing your experiences, both very professional as well as personal ones. And with that, we'll close the session. Thank you all for being here as well. And as we are ending, we can perhaps take a photograph together, all of us.
Like to have,
Yeah.
everybody would like to have a photo.
Okay, sure.